Hi there everyone, welcome to our very next video in our INBDE lecture series on all things essential in medicine. In this lecture series video, we're going to be starting off by talking about diabetes. And so when it comes to diabetes, we have two types that we're looking at primarily. So we have diabetes mellitus, which is the most common type relative to diabetes insipidus. And then diabetes insipidus, which is a condition where the kidneys are actually unable to retain water just because the body can't respond to antidiuretic hormone. Or there could be a lack of antidiuretic hormone, and that's going to result in patients experiencing polyuria and then subsequently polydipsia, so excess urination and then being extra thirsty as a result. And so we'll start off with talking about diabetes mellitus and its pathophysiology. So with this condition, we have high blood glucose concentration because the body is either unable to produce or properly react to insulin. And so that high blood glucose is going to result in endothelial cell damage, which can result in a plethora of other things such as atherosclerosis, neuropathy, gangrenous necrosis, hypertension, and so forth. And so with diabetes mellitus, there's three main things that characterize it. So patients experience polydipsia, so they're extra thirsty, polyphagia, and satiable hunger, and then lastly polyuria or excess urination. And so with diabetes mellitus, there's also two subtypes of this. You have type 1, you can also have type 2, and then there's also even gestational diabetes, which we'll talk about in this next slide coming up. So with type 1 diabetes mellitus, this is where we have autoimmune destruction of our pancreatic beta cells, and that's going to result in low insulin levels or insulin deficiency. This is typically seen at a younger age, so it has a childhood onset, and all these patients are going to be on insulin because of that autoimmune destruction of the beta cells which produce it. And so type 1 diabetics are insulin-dependent diabetics. And so this lack of sugar in your cells is going to result in lipids being used for energy. And so these patients can suffer from what's known as ketone breath, which is where their breath has a fruity odor to it. And then we have type 2 diabetes. And so this is actually going to account for about 90% of all diabetic cases. This has a later onset, typically in adulthood, and insulin is only required in severe cases. Most cases of patients that have type 2 diabetes mellitus are actually not insulin dependent. And this type of diabetes can actually be prevented and even controlled pretty well with proper diet and exercise. And so patients with type 2 diabetes are going to be categorized as being insulin resistant. And lastly, we have gestational diabetes. So with this, we have placental hormones causing insulin resistance and sensitivity in pregnant patients. And so you have a mix of type 1 and type 2 diabetes that resolves after pregnancy is over. I also want to talk about blood glucose and HbA1c a little bit. So blood glucose is measured in milligrams per deciliter. It's not a very reliable measurement in terms of diabetic control because it's going to fluctuate throughout the day. HbA1c is a lot better. And so this is measuring the percent of glycosylated hemoglobin in our patients. And that HbA1c measurement is going to be good for about 3 months because that is the lifespan of a red blood cell. And so HbA1c is going to be inversely proportional to a patient's blood sugar control. And there's also various measurements to be aware of, as well as some important measurements when it comes to different types of tests to be aware of and kind of have locked down and memorized for the exam to help categorize patients. So for diabetic patients, that's when their HbA1c is 6.5 or above. If they're pre-diabetic, their HbA1c is going to fall in a 5.7 to 6.4 percentage range. And then normal healthy patients are going to have an HbA1c of less than 5.7. And so I have this here for you from the CDC. It's really good to look at and be aware of and just kind of commit to memory short term for the board exam. All right, next up we'll talk about hypoglycemia. And so with hypoglycemia, this is defined as your blood sugar dropping below roughly 70 milligrams per deciliter. And so there are some dental concerns that we have with patients experiencing this. You have excess insulin and you have low blood sugar, and that can result in insulin shock. And so, for example, a patient could feel faint after you give them local anesthetic, for example. If If patients lose consciousness that are suffering from this, we want to call 911 and try and provide them either IV dextrose or even IM glucagon. If that patient's conscious, you can look at finding them a ride back from your dental office, give them some orange juice, cake frosting, glucose tablets, whatever sugary thing that you could have they could consume in your office would really help. These patients also exhibit certain signs and symptoms, which can be remembered with the acronym TIRED. So they are going to be tachycardic, irritable, restless, extra hungry, and even diaphoretic or sweating a lot. So cold and clammy, need some candy is a very common phrase used to describe these patients in dental schools. And then on the other hand, we have hyperglycemia. And so with hyperglycemia, this is when patients have that fasting blood sugar of either 126 milligrams per deciliter or higher, or a post-meal blood sugar of 200 milligrams per deciliter or higher. And so one way to remember the signs and symptoms of patients that experience hyperglycemia is with the acronym SINFUL. So they're going to have that sweet ketone breath, increased thirst, nausea and vomiting, frequent urination, and loss of vision. And so hot and dry, sugar high is another common phrase used to highlight patients suffering from hyperglycemia as well in a dental school setting. And with diabetes, there are some oral health effects and risks associated with that condition that we'll talk about, such as xerostomia from multiple medication used to manage it. Patients can also suffer from burning mouth, altered wound healing, being more risk for infections, especially after things like full mouth extractions, and suffering from an increased risk of candidiasis. These patients can also be at higher risk for caries, suffer from gingivitis and periodontal disease as well at greater rates than a normal patient who is not affected with diabetes. When it comes to emergency management of diabetics, so those that are hypoglycemic, it's important that conscious patients be given some form of glucose. Again, whether it's a dextrose or glucose tablet, orange juice, cake frosting, something else that you can find with sugar in it for them. And then if they're unconscious, look at giving them IV dextrose or IM glucagon. And then diabetic patients and IV sedation. So for these types of patients, we want to look at getting them a medical consult, having a low-calorie meal before care, and then looking at getting their insulin adjusted based off their physician's recommendation whenever you submit for that consult. And then next up, we're going to talk about diabetic ketoacidosis and Kussmaul breathing. So diabetic ketoacidosis, this is a type of metabolic acidosis from ketone production as a result of hyperglycemia in these patients. It's mostly going to be seen in patients with insulin-dependent or type 1 diabetes. And so they have that ketone breath like we talked about earlier, where their breath smells a little bit fruity. These patients can suffer from what's known as Kussmaul breathing, which is a quick way to identify them. So it's a type of deep, rapid, and labored breathing that occurs as a compensation to the metabolic acidosis they're suffering as a result of their hyperglycemic state. And they're simply blowing off excess carbon dioxide to help raise their blood pH. And then when it comes to diabetic patient management, for diabetics that have things pretty well under control, we want to try and prioritize short morning appointments. We also want to look at keeping a glucose source on hand for any sort of type of emergency and using a glucometer to measure their blood glucose. There's some important medical medications that we need to be aware of as well, and their interactions and how they can affect diabetics that are well controlled. So NSAIDs and sulfonylurea medications, this can actually exacerbate a hypoglycemic state. Glucocorticoids can make a patient more prone to hyperglycemia, and then levofloxacin can also exacerbate hypoglycemia. When it comes to poorly controlled diabetics, we want to submit out for a medical consult, delay all elective treatment until we get that back and get that patient cleared, and provide emergency treatment only if that patient is not experiencing diabetic symptoms. So we want to look at conservative treatment and referring them to their physician for clearance, as well as getting them a game plan with their doctor to get their blood sugar under control. If a patient is experiencing diabetic symptoms, that's when we want to send them directly to the ER. So thank you guys so much for tuning in to this video for our masterclass lecture series on all things essential in medicine. I'll see you guys next time.